Good evening, Parul. We can start. Good evening, Parul.
Good evening, sir.
Yeah.
Good evening, sir.
Good evening, Richa. Good evening.
Good evening, everybody.
Minji.
Good evening.
Good evening.
Good evening, sir. May we start, sir?
Yes, Parul. Go ahead.
Good evening, respected seniors, dear colleagues and students. On behalf of ISA National PG Online Classes, I welcome you all to this edition of PG Classes. Before we start our session, let's pray to Goddess Saraswati to bless us with heightened knowledge and wisdom. Today's session is on short cases. As the exams are fast approaching, a comprehensive anesthesia examination preparation is the need of the hour. As our senior teachers observe and realize that students really work hard for long cases and grand viva, but generally neglect the short cases. So we learned the precise method of answering short cases today. The first case is ICD in situ, and second is anesthetic management of a tracheostomized patient. So before we start the session, I request all of you to mute yourself. You can post your questions and queries in the chat box, which will be taken later in the course of time. To handle today's session, we have two eminent chairpersons, Dr. Sanjeev Palta, who is the professor and head at GMCH Chandigarh. His area of interest are perioperative and critical care ultrasound, critical care. He is an FCCS instructor, level 2 ultrasound provider. He has received the state award for exemplary work during COVID and has 75 publications to his credit and 12 book chapters. Our second chairperson today is Professor Richa Saroa, who is a professor at GMCH Chandigarh. Her area of interest is ultrasound-guided regional anesthesia and ultrasound in critical care, labor analgesia, focus, and critical care. She is an ACLS instructor and an FCCS instructor and has conducted several workshops on use of ultrasound. She is a USG regional anesthesia level 1 provider and has 55 international and national publications and 12 chapters in the books. We have two speakers today, or the people who will be presenting the cases. Dr. Anmol Jindal, who is a postgraduate student at Government Medical College Hospital, Chandigarh, and Dr. Kushalkra, who is a postgraduate resident at GMC, Chandigarh. May I request the chairpersons to take over the charge and please enlighten the audience today. Thank you so much. We are going live and the talk will be later available at YouTube and at official website also. Thank you so much.
Thank you, Parulji, for this introduction. And may I now request Dr. Richa to please start the short cases and with her first case and Dr. Anmol Jindal to please present.
Thank you, Dr. Parul, for the introduction, and thank you, ISA, for giving us this platform. Thank you, Palta sir, for giving the permission to start on. I would request Anmol, we'll be taking the first case with the intercostal chest drain in situ as a short case for benefit of postgraduate students. And I would request Anmol to kindly share her screen so that we can start with the short case. Anmol, please.
I'm sorry, Dr. Parul? Dr. Parul, can you unmute Kushagrata and Anmol, please?
Yes, sir. Just a minute,
Please.
sir.
Good evening, Dr. Bajwa ji.
Sir, Kushagra and Anmol, have they, by which name have they logged in? Because I cannot see their
आप
names.
कुशाग्रता देखेंगे उधर कुशाग्रता आ रहा होगा. I'll ask them. I'm just on the phone with her.
Sir, I'm checking.
कुशाग्रता
Don't
लिखा
worry,
आ
sir.
रहा है बेटा.
Just checking it out.
हाँ जी sir.
कुशाग्रता किस नाम से हो?
Ma'am, Kushagrata hai.
कुशाग्रता अनमोल तेरे. So through the computer of Kushagrata, Anmol will be joining. So just
Right,
unmute
sir.
Kushagrata, please.
Yes, sir.
Okay, thank you.
They're trying to join. Actually, they're unable to share their screen. Anmol, can you please listen?
Ma'am, I've asked them to unmute themselves. They have.
Dr. Bajwa, make them co-host.
Already made. Kushagrata made co-host. She can share the screen now.
So, Anmol, yes. Are you able to share your screen now?
Ma'am, I'm just trying, ma'am. Share.
Okay, that's fine. So we take up the first case discussion on intercostal chest strain. For the benefit of the postgraduate students, we have just given a short case summary and not gone into the much details of the case. And after that, we have tried to make the case in a question answer format as and when the questions can be asked pertaining to the intercostal chest strain. And later on, I will discuss certain other things. So over to you, Dr. Anmol. Thank you.
Good evening, everybody. Now I'll be discussing my case. I'll be starting with the case summary. I'm presenting a case of 40-year-old female who presented to us with the chief complaint of cough with expectoration since 1 month, fever since 5 days, chest pain since 2 days, difficulty in breathing since 24 hours, with past history of pulmonary tuberculosis for 12 years back. And the patient did not give any other history of any comorbidity. On examination, it was found that the systolic blood pressure was on the lower side. Tachypnea was present with decreased breath sounds on the left side, with room air saturation of 92%, and her breath holding time was decreased. On inspection and palpation of the respiratory system, the movement on the left side of the chest was less, and the trachea was deviated to the left side, and the tracheal tenderness was present. The left side was dull on percussion, and the intercostal tenderness was present. The crepitations were present on auscultation on the left side. Later, the left-sided intercostal drain was inserted, and patient was improved symptomatically.
So as far as the history is concerned, as in short cases, so Anmol, what is your differential diagnosis in this case?
Ma'am, going by the history and the physical examination, my differential diagnosis would be empyema, lung abscess, pneumonia, and the bronchopleural fistula associated with the chronic infection.
Okay, so you said that there's an intercostal drain in situ, right?
Yes, ma'am.
So what is actually your intercostal chest drain and what is the function of the same?
Ma'am, the intercostal chest drain, it is a flexible tube that is inserted into the pleural cavity through the chest hole to drain out any pleural collections. Ma'am, it is done to facilitate the re-expansion of the collapsed lung due to the pleural collection, and also to avoid the rise in intrathoracic pressure, which can further lead to hemodynamic compromise.
Okay, so for the sake of the house, can you please indicate what are the various indications for the chest drain placement?
Ma'am, the various indications of ICD placement are pneumothorax, hemothorax, chylothorax, empyema, bronchopleural fistula, pleural effusions, and ma'am, for traumatic hemopneumothorax, ma'am.
Okay, and what are the contraindications of ICD insertion? Are there any contraindications you know of?
Ma'am, the contraindication to ICD insertion can be divided into absolute contraindication or the relative contraindication. Ma'am, in the absolute absolute contraindication, we have when there is a pleural adhesion at the site of the ICD insertion, or when there is a need of emergency sternotomy or thoracotomy. However, the relative contraindication include the coagulopathy, infection at the site of insertion, emphysema emphysematous bullae diaphragmatic hernia, or the transuative effusions, ma'am.
Okay, so Anmol, can you just let me know that like when you have to play a chest drain electively, or when you have to place a chest drain in an emergency procedure, what is the site of chest drain insertion?
Ma'am, when we are talking about the elective chest drain insertion, ma'am, it is placed in the 4th to 5th intercostal space in a triangle of safety, which is formed by the lateral border of pectoralis major and the anterior border of latissimus dorsi. The base is formed by the 5th intercostal space or the 5th rib, and the base is formed by the axilla. And when we are talking about the emergency situation, we usually do it in the mid-clavicular line in 2nd intercostal space, ma'am.
Okay, so for the house, actually, we'll expect an answer from the house later on from all the other PGs that why it is known as triangle of safety. Why this particular triangle is always chosen for insertion of chest drain, but I'll expect this answer from other postgraduates. So this is a mind tickler for all of them, why it is known as triangle of safety. Okay, so Anmol, what are, when you talk about chest drainage system, okay, so what are the components of a chest drainage system? Are there any components which are important and integral to this drainage system?
Ji, ma'am. Ma'am, the components of the chest drain system includes a chest tube, which is inserted into the pleural cavity, a drainage tube, which is connected to the chest tube and opens into the chamber, which is the collection chamber, and then the underwater seal that is formed by the drainage tube, which is immersed 1 to 2 centimeter into the collection chamber. And ma'am, the collection chamber, it should be placed at least 100 centimeter below the drainage side.
Okay, wait and more. Again, I would like to question again to all the house that why is always chest drainage system placed at least 100 centimeter below the chest? We will answer this question later on, but I expect this answer from everyone else also. This is the second question, which I think the PGs can answer. So we can move on to the next question. So what are the available sizes of the chest drain?
Ma'am, the various sizes available for the children, we have size of 6 to 40 French, and ma'am, for the adults, ma'am, we have size. We select the size as per the indication of chest drainage, chest tube insertion, ma'am. Ma'am, like for pneumothorax, we usually go for smaller size, like 24 to 28 French, and however, for the thick secretions like pus and the blood, we go for the larger size, that is 36 to 40 French gauge, ma'am.
So when we talk about the various sizes, you have already discussed it, and for everyone, whenever you see there's an indication, you have to choose your chest side or ICD intercostal side tube size accordingly. So now, if we are talking about the systems, what are the various types of chest drain systems which are, discussed traditionally or which are available otherwise?
Ma'am, the types of chest drainage system available to us, they are the 1 bottle system, 2 bottle system, 3 bottle system, or the 4 bottle system, depending.
So here I would take the, this thing, ki Anmol, can you just, post the pictures of all these type 1, 2, 3, and 4 systems, and then, kind of explain them?
Ji, ma'am. Ma'am, coming to the first bottle drainage system, in this system, we have a drainage tube from the patient, which forms the underwater seal. That is, it is immersed up to the 2 centimeter in the fluid that is present in the collection chamber. The diameter of the collection chamber should be 20 centimeter, and we have a vent that vent out the gases from the to the atmosphere, ma'am. The disadvantage of this system is that when there is excessive fluid, there will be rise in the fluid level, which will provide resistance during the expiration and will increase the work of breathing of the patient. So to overcome this problem, we have two portal drainage system. As we can
First of all, you also need to remember for everyone that the single bottle drainage system is the most frequently used drainage system. Okay. In our clinical practice. So next, yes.
Hanji, ma'am, one more thing, that we have to keep this collection chamber at least 100 centimeter below the drainage site, ma'am.
Yeah, that's somebody has answered it correctly in the chat box, and that's nice. And what is can you move this tube in and out? What does it generate? Anyone else? What kind of pressure it generates? The tube which is coming from the patient, which is going inside the bottle water. Underwater
Our
seal.
audience can either mute themselves right now, or they can.
No, they can write in the chat box. They are writing it in the chat
write
box.
it in the chat box.
Yeah,
Yes,
yeah,
ma'am.
they're writing there in the chat box. They're answering it. So I'm happy to see that. So anybody who can write it in the chat box that yes, it will create a negative pressure. Nice, but how?
Ma'am, somebody is saying it is because of the 100 centimeter. It allows for negative pressure as high as 80 centimeter water, and a pressure gradient is thus created.
Yes. Anmol, you can discuss the next.
Ji, ma'am. So as we have discussed, the fluid level will keep on rising if there is excessive fluid, and will lead to increasing resistance during expiration and increased work of breathing. So to overcome this problem, we have two bottle drainage system. In this system, we have a fluid collection chamber. That is, the drainage tube coming from the patient, it will drain the fluid in the collection chamber. However, the gases, they are vented to the second bottle, that is our water seal. And from there, the gases, they are vented out to the atmosphere. So it will not increase the underwater seal level, and thus the problem which was associated with single bottle will be eliminated. However, it relies on the gravitational pressure, negative pressure, to drain the pleural collection, but sometimes we might need suction to drain the collection. So to facilitate that, we have three bottle drainage system. In this system, along with fluid collection and water seal, we have another bottle, that is the suction regulation bottle. In this system, we have a suction tube that is attached to the suction. The pressure of the suction is around 10 to 20 centimeter of water, and then we have a vent tube that is immersed into the water of up to 20 centimeter. That is the pressure that to regulate the negative pressure that is generated by the suction, and on the other end, it is open to the atmosphere.
Where is this three bottle drainage system commonly seen for all the from all the anybody? You can write it in the chat box. Okay, where this three bottle drainage system is most commonly seen. So Anmol, you can move on to the fourth drainage system.
Then we have the four-chamber drainage system. In four-chamber collection system, along with the three-bottle system, we have additional vent bottle or the underseal water. This is added to prevent pneumothorax if the suction fails. So this overcomes the disadvantage of the three-bottle system, ma'am.
Yes. So now what are the complications, various complications which you know of, which are associated with intercostal chest drain placement?
Ji, ma'am. Ma'am, the complications associated with intercostal chest drains are hemothorax. There can be injury to the lung or the abdominal injury or any major thoracic structural injury, or there could be incorrect positioning of the ICD. There could be cardiac dysarrhythmias while placing the ICD, or there could be accidental disconnection. There is a risk of infection, and later on it can the patient might also develop re-expansion pulmonary edema.
Okay, so how will you manage your chest drain in intensive care units when we talk about critical care units?
Ma'am, the management of ICD in ICU, it includes that we have to avoid clamping the ICD if there is air leak or the fluid coming or there is a fluid output. Secondly, we have to examine the ICD daily, and we have to document the amount of fluid collected in the collection chamber, and then we have to correlate clinically. We have to ensure that the collection chamber is always below the patient's at the patient's chest, that is the drainage side, at least 100 centimeter. And then we have to check the patient is not lying over the ICD, that is to prevent any kinking or disconnection. We have to obtain a chest X-ray post ICD insertion and at regular periods. Then we have to change the dressing of the ICD frequently to minimize the infections. And if the large pleural fluid is to be evacuated, it has to be evacuated slowly so that it should not be evacuated more than 1.5 liters at a time, ma'am.
Why?
Ma'am, then otherwise it will lead to the re-expansion pulmonary edema, ma'am.
Okay, so what could be the possible reasons? You one day you go in ICU and you find that the water column, or this is known as tindling also, it is no longer oscillating. So if you go and find that, what are the possible reasons of the same?
Ma'am, if the water column is not moving, that is, there is absence of tingling, it could be because of there could be the chest tube may be clamped, or it could be kinked. There would be the blockage of the ICD eyes, that is the opening in the chest tube that is in the pleural cavity, or there could be blockage due to the blood clot, or the another thing is that the chest might have re-expanded, and the pathology for which the ICD was inserted has been resolved, ma'am.
So that should have been the first thing, right? The other things, yes, you have to rule out the clots and everything, but you must also think of that it has re-expanded, the chest has re-expanded. Most of the time, we'll not see that, right? Okay, so now you have been talking about, re-expansion pulmonary edema after chest tube insertion. So tell me, what is re-expansion pulmonary edema and how it can be avoided?
Ma'am, the re-expansion pulmonary edema is it is a rare condition, but it is a life-threatening condition. It is seen due to the reperfusion injury, which leads to the increased vascular permeability. Usually, this condition is self-limiting and it requires only the supportive treatment. And as we have discussed, that the precaution that we can take to avoid this condition is to drain the fluid slowly, like we have discussed, that no more than 1.5 liter to be evacuated at a time, ma'am.
Good. Okay. So now, when do you think that you can remove a chest drain?
Ma'am, the chest drain can be removed if there is improvement in the clinical condition, that is the lung has re-expanded and there is no or minimal fluid collection. The auscultatory findings, they are normal. There are normal vesicular breath sounds bilaterally, and our findings can be confirmed either on X-ray or on ultrasound. The X-ray will show the fully inflated chest, and there would be in the ICD, the per day fluid collection should not be more than 200 to 300 ml, and it should be non-infected fluid. And on ultrasound, we can confirm it by seeing the lung sliding sign and the seashore sign on M mode.
Okay. So as far as the short case is concerned, when pertaining to the ICD, intercostal chest drain in situ, you will usually be asked questions up till this. But for the benefit of the postgraduate students, are not taking much of the time, because we are already at the fag end and we've kept 5 minutes for discussion, for questions. But for the postgraduates, if you get a long case with an ICD insertion, with an ICD in situ, just 2 slides that what all need to be evaluated and what all you need to cover up for a long case. So you must go through your books and study all these points if you have such a case for an long case. I will tell Anmol to please go through the slides.
So the anesthetic management, we will be like covering only the important headings under which which are important pertaining to the long case discussion. First of all, if we have a patient with ICD in situ, the surgery that could be planned for the patient are lobectomy, pneumonectomy, pleurectomy, or decortication. The anesthetic, as an anesthetist, our aim should be to review the respiratory anatomy and physiology. We have to discuss the assessment of the pulmonary system and recognize the indication of ICD insertion. We should also know about the bedside pulmonary function test, the preoperative respiratory assessment that include the three-legged stools, in which we study the lung mechanics, the lung parenchymal function, and the cardiopulmonary function. We should know about the one lung ventilation, its physiology, both in open and in closed chest, and in spontaneous and mechanical ventilation. We should know the various techniques to achieve the one lung ventilation, the various types of a double lumen tube, which could be hooked or non-hooked, and the sizes they are available in, and the other methods that are the use of bronchial blockers, which are ardent blocker, easy blocker, fusy blocker, or the Cohen blocker, and the univent tubes. Another thing we should know about the perioperative management of one lung ventilation and its associated complications, the methods to achieve one lung ventilation in children, the alternative ventilation strategies, which include the high frequency oscillatory ventilation or the jet ventilation, and the role of TIVA in thoracic surgery. Along with we should also know about the role of thoracic analgesia and regional blocks for postoperative pain relief.
So thank you so much, Anmol. I think we are just done in half an hour. So this is open for discussion, please.
Ma'am, there were two questions you had asked during your case presentation. Ma'am, you had asked, why is it called as triangle of safety?
Yeah, they have absolutely given the right answers, actually. So it's a neurovascular space. There are no major blood vessels. So it's an atraumatic space, and that is why. And somebody has correctly written about the maximum pressures, pleural pressure, negative pressures, pleural pressures that are generated in tension pneumothorax is up to 80 centimeters of water. So to maintain a positive pressure gradient so that fluid or air can flow from a positive to a negative, that is why it is kept at 100 centimeter. So that is, they have answered it very correctly.
Ma'am, the second question you had asked was, where is the three-chamber pressure drainage seen? So the answers which you have given is hydropneumothorax and pneumothorax. So, ma'am,
no,
are they right?
The three-chamber seal, basically, if you go to the cardiac surgery OTs, basically, and you can see the three-chamber drainage system there. So if you happen to visit your cardiac CTVS, please look at the post-op area also. They usually have, they attach the three-chamber ICD drainage systems in the ICU, and they're very, very particular about maintaining the suction pressures and everything. So that is where you will see the three-bottle system.
Thank you so much, ma'am.
Yeah, so I think we can open it for the questions.
If anybody has a question, please post it in the box so you can unmute and ask ma'am.
Please ask Anmol.
Okay.
I'll be happy to answer.
Otherwise, till the time the questions are coming in the chat box, can we start with the second case, please?
Yeah.
Hello.
Yes.
Can we start the second case?
Can we please start with the second case, please?
Yes, ma'am. Please, we can start. I'll let you know the questions at the end of the second case also.
Yeah. Thank you.
Thank you so much, ma'am.
Thank you very much, and thank you, Dr. Chaji. And now, Kushagrita, are you there?
Yes, sir. Yes, sir.
Okay. Dear students, first of all, I'm in my regards to Dr. Naveen and Dr. Sukhminder Bajwa, and thanks, Parul, for coordinating this excellent webinar for the short cases. I have also kept the pattern of the short cases in the same, because once you get in a short case in your Viva, final MD Viva, usually the time given is small, because you have to complete 2 short cases in one station. So naturally, the examiner is not that much interested in knowing about the history and other things about the past or something. They want to have a kind of summary for that particular patient, and then the questions are pertaining to the problem in that patient. So again, the pattern will be same. I'll be asking the questions, to Kushagrita. Kushagrita will be displaying those questions and Kushagrita will be answering those questions. And after the answer, the slide of the answer will also be displayed over there. Kushagrita, I think you can start over there. Thank you.
Yes, sir. So I'm presenting a case of 40-year-old male resident of Ambala, Haryana, informant is patient's sister, 37-year-old graduate, and seems to be a reliable source of information. Chief complaints: patient is a known post-operative case of carcinoma trunk with tracheostomy tube in situ, presented in ENT emergency with the complaint of difficulty in breathing since 10 days. Now moving on to history of present illness.
Sorry, Kushagrita, I think its summary is more important because nobody's going to ask you all this thing, history and this thing, right?
Okay,
I just want to know what exactly the problem of this patient, because you said the patient is having a difficulty in breathing, and that too when the patient is tracheostomatized. So what could be the cause of this difficulty in breathing? Give the summary and give the answer for that, please.
Yes, sir. So I'm presenting the summary. It's a 40-year-old male known post-operative case of carcinoma tongue post-chemotherapy. Last cycle was given on 22nd October and radiotherapy last cycle given on 15th February 2022. And at present, patient is without any other known comorbidities with tracheostomy tube in situ and is presented with a difficulty in breathing. So this could basically be due to the poor domiciliary tracheostomy tube care, which is leading to the blockage of the tracheostomy tube.
Kushagrita, if you think the blockage is there, then how come that the patient is taking 10 days to come to the hospital?
Sir, maybe the blockage that has been there is gradual. It has not been like some clot or some other thing has not blocked the tube because of the retention of the secretions over the period of time, and because of the poor caring of the tube, the patient has landed up with blockage finally when the crustings have been formed inside.
Okay, so did you ask the history about any blood coming through the tracheostomy tube?
Yes, sir. So there was no discharge coming from the no bloody discharge coming from the tracheostomy tube as such.
So what could be the reasons of blockage then?
Sir, maybe because of the mucoid secretions that are there, which a patient was coughing out because of any chest infection that the patient had that lead to the secretions to the tracheostomy tube.
Okay, most of the time, because once the patient is at home and like once you're taking care of tracheostomy in ICU, we tend to give patient a humidifier air. Now, what happens is at home, the patients, they are not trained enough, or the relatives are not trained enough to at least put in a kind of a soaked, water-soaked gauze piece over the whole of the tracheostomy tube, so that the humidified air goes over there, and persistent inhaling of dry gases, because that upper respiratory path is already bypassed. It leads to inspission of the secretions also. So this thickening of the secretions, and if you're not taking adequate care in taking the secretions out, or if the patient has not been trained enough to cough out the things, this may lead to blockade of the tracheostomy. And then the patient can land in any kind of a dire emergency, bringing to the hospital. So this is the brief summary, and based upon this, we are going to start with a tracheostomy. Apparently, the thing for an anesthetist, it looks like a very common thing that it is a tracheostomy, already the airway is secured, not much to be done, not, much of the challenges available over it. But it is on the contrary, entirely a different thing, that tracheostomy in itself is a very, very important procedure which has been done. And for the anesthetist, working in two environments, one in a perioperative environment and another is in the critical environment, it becomes very important how to take care of that. So I'll be starting with the questions now, Kushagrita.
Yes,
so
sir.
can you describe the anatomy of larynx with respect to the tracheostomy, please?
Yes, sir. So grossly, as we all know, the larynx basically consists of 3 paired and 3 unpaired cartilages. But with respect to the tracheostomy, most important is the anterior aspect of the larynx that is important for us while performing the tracheostomy. Sir, in that, first of all, there is a hyoid bone which is connected to the thyroid cartilage by a thyrohyoid ligament, and then below thyroid there is a hyoid bone which is connected to thyroid by thyrohyoid ligament. And sir, below that there is the beginning of the tracheal rings, which are basically incomplete rings, which are posteriorly there is absent ring, and only the anterior surface there is the ring. And then these tracheal rings further divide into 2 left and right bronchus and further supply the lungs. So sir, most important over here is the isthmus part of the thyroid, at which the tracheostomy is normally done.
Okay, can you show the slide please now?
Yes, sir. Sir, in this diagram, as we can see, this figure shows the thyroid cartilage, and over here this is the isthmus part, and over here we do the tracheostomy most commonly is done at the second and third ring.
So now can you tell me what exactly is tracheostomy?
Yes, sir. So tracheostomy is basically a procedure in which an incision is made over an airway and a tube is passed through the airway so as to maintain the opening of the airway permanently or temporarily.
Okay, please show the slide over there.
Yes.
Now it is in a procedure in which the incision is made over the trachea. Okay. And then you have done the tracheostomy over there. That's done. So, okay, the next question is, what could be the indications for this kind of a procedure?
So tracheostomy, as we all know, is either performed perioperatively or it is usually done in critical care settings. So accordingly, we can divide the indications that are there for tracheostomy. The indications can be perioperative conditions and critical care conditions. First of all, the critical care conditions. It is usually done in the cases where prolonged mechanical ventilation is required, like in cases where there is respiratory disease, there is neuromuscular disease, depressed mental status is present, and it can even be used for tracheobronchial toileting. But sir, perioperatively, it is mostly done for airway obstruction, and it can be done for surgical access that is needed in major surgeries of head and neck region, extensive maxillofacial surgeries. Postoperatively, also tracheostomy can be done. It is mostly done in the cases of CA larynx, where a laryngectomy is done intraoperatively so as to maintain the patency of the airway. In the postoperative period, tracheostomy will be needed. And the other indication being where there is large thyroid mass and there is damage to more of the tracheal rings. So we have a risk of airway being damaged. So in these cases also, we are doing tracheostomy.
Okay, thank you very much. And show me the slide, please, now.
Yes, sir.
So these are those perioperative indications and the critical care indications for doing a tracheostomy. So since this is what we have discussed about the adults, do you know the indications of tracheostomy for infants and children?
Yes. So usually in infants and children, tracheostomy is avoided because the tracheal rings are not that well formed, and it is difficult to do this procedure in this age group. But there are specific conditions in which we have to do the tracheostomy. In infants, these conditions include subglottic hemangioma, subglottic stenosis, laryngeal cyst, if there is bilateral vocal cord paralysis. Whereas in children who are a bit older in age, in that acute tracheolaryngobronchitis, then there is epiglottitis, diphtheria infection can be there. There can be external laryngeal trauma, and there can be prolonged intubation like post pneumonia in these patients. So in those patients also we go for tracheostomy.
Show me the slide, please, now, for the benefit of the house. So these are the indications in infants and children going in for the tracheostomy. So going for the procedure, what could be the advantages or disadvantages for this tracheostomy procedure? I'm talking now about the adults.
Yes, sir. So as we all know, the procedures are combined. There are both advantages and disadvantages. So first of all, I'll be starting with the advantages of tracheostomy. So that is better tolerated by the patients. There is oral hygiene is better maintained. We can even provide oral nutrition to the patients, and we can keep the patients in ICU. We can keep the patients off ventilator, so there is less a risk of ventilator associated pneumonia. It avoids endotracheal tube complications. Speech is possible with the help of speech therapist and by using specialized tracheostomy tubes, and there is enhanced mobility in these patients. Moreover, sir, in the physiology of the airway, there will be decrease in the dead space. Airway resistance is decreased. The work of breathing is decreased. There is less incidence of vocal cord injury and sinusitis, and laryngeal ulcerations are also decreased, which can occur in case of intubated patients. But sir, moving on to the disadvantages, there is, as we all know, it is an invasive procedure and we need to learn the procedure, so skills are required. There can be tracheal complications in the later on periods. There is risk of infection and bleeding, and then psychological trauma can be there because the patients, they have to keep the tracheostomy for a longer period of time. So society pressure and psychological trauma can be associated with it, and there can be risk of accidental decannulations when we are sending the patients in the ward or when we are sending them home with the tracheostomy tube in situ.
Okay, but most of your advantages which you have told us, they are pertaining to the patient in a critical care. But one of the very big advantage in the perioperative period is once the tracheostomy is done, at least we, with respect to the head and neck surgeries or in like CA larynx surgeries, when the tracheostomies are done, at least it provides a very secure airway for the anesthetist to manage. So
Yes.
that is a very big advantage. And sometimes the tracheostomies are preemptively done in the perioperative period, so that the surgical site as well as the the anesthetic area, do not overlap with each other. The rest of the things are okay for you, what you are telling. Now tell me once, describe the complications of tracheostomy.
So tracheostomy complications can be broadly divided into three time periods. There are immediate complications which occur when the procedure is being performed. There are intermediate complications which occur from few hours to few days. And then there are delayed complications which can occur in the later on periods. So for the immediate complications, the most common complications are hemorrhage. Apnea can be there when we have lost the airway. Pneumothorax can occur. There is injury to the recurrent laryngeal nerve. Aspiration of the blood can occur. And sir, in moving on to the intermediate complications, they basically include bleeding. There can be displacement of the tube, blocking of the tube, subcutaneous emphysema, which can occur around the suture sites. There can be tracheitis or tracheobronchiolitis. And so for the delayed complications, also hemorrhage is a main complication that occurs. There can be laryngeal stenosis, there can be tracheal stenosis, there can be corrosion of the tracheostomy tube, and scar and keloid can form at the site of the tracheostomy, and tracheoesophageal fistula can also occur. So in the immediate complications also, there can be esophageal injury which occurs at the time of performing tracheostomy, leading to tracheoesophageal fistulas in the later on period.
Okay, Kushagrita, there's one question over there in the chat box. Anybody who wants to answer first, and that is, are there some chances of tracheal trauma during intubation leading to bilateral pneumo and subcutaneous emphysema with crepitus?
Yes, sir, there are chances, sir.
How? Please explain. Tracheal trauma during intubation. The question is tracheal trauma during intubation.
Sir, because one of the reason is traumatic intubation when we are doing, if the laryngoscope blade can it can hit, and then that time also there can be a rent that can be there. There can be a small opening that can be created that can lead to subcutaneous emphysema.
How? Do you think the tracheostomy? Do you think the endotracheal intubation, the tube is that long? There is some other reason. People are giving the answer. People are already giving the correct answer over here. What could be the thing?
So because of the use of the stillet that they're using.
Yes, because of the use of the stillet, which can perforate and can cause this problem. Okay?
Yes, sir.
Fine. So show the slide of the complications of tracheostomy, please.
Yes.
So these are the complications of the tracheostomy. And now once we have discussed about this procedure, let's see what kind of tracheostomies are available with respect to the site. How do we label the tracheostomy, whether it's high or low tracheostomy? So what are the types of tracheostomy now?
So broadly, we can divide the tracheostomy into elective tracheostomies, which can be done for therapeutic purposes or because of prophylactic purposes. There are emergency tracheostomy, which are done, which are a part of difficult airway algorithm also. So then permanent tracheostomies can be needed in some conditions. There is percutaneous dilatation tracheostomy, and there is mini tracheostomy, which is cricothyroidotomy. And so depending upon the level also, it can be high tracheostomy, which is above the level of the thyroid isthmus. It can be mid or it can be low. Mid is through the second and third tracheal rings, and the low tracheostomy is below the level of the isthmus of the thyroid.
This is very important for everybody to know that the critical care physician is doing the tracheostomies in the ICU only, which is percutaneous dilatational tracheostomies. But still, this is an important question to know. Show the next slide, please.
Yes.
Yes, that according to the site of the tracheostomy, it can be high, it can be mid, or it can be low also. So these are the type of the tracheostomies which are done. And now coming back to, let's discuss something about the tracheostomy tube as such. Please describe the parts of tracheostomy tube.
Yes, so for describing the parts of the tracheostomy tube, I would like to show a diagram in which I can describe the parts.
That will be much better, please.
Yes, sir. So basically this image shows a double lumen tracheostomy tube. In tracheostomy tube, grossly, we can say that there is a patient end and then there's a machine end. So the patient end is basically the end that goes inside the patient. It consists of a cuff, which is usually a low pressure, high volume cuff. There is an inflation tube, which is connected to an inflation balloon, which further consists of one-way valve. And so inside this tracheostomy tube, we can inside this tracheostomy tube, we can pass the hollow inner cannula, which can be removed and cleaned time to time in double lumen tubes. Then there's an obturator with the rounded tip, which is usually which guides the insertion of the tracheostomy tube. And at the patient end, there's a flange which fixes the tracheostomy tube outside the stoma. And so then there are tracheostomy tie strings with which we are tying the tracheostomy around the neck of the patient and securing it the tracheostomy.
Okay.
And
Thank
so
you.
then for the
Okay.
classification of the tracheostomy tube, we
That's
can
also
divide them in
important.
various ways. Sir, in that the tube can be either cuffed or uncuffed if the cuff is present or not. And so depending upon the material also, we can further divide them. It can be made of polyvinyl chloride, can be made up of silicon, or a mixture of both, or metallic tracheostomy tubes as we used in earlier days. So then the tubes can be fenestrated or unfenestrated tubes, and depending upon the lumen also double lumen.
Please change the slide also.
Yes, sir.
Okay.
And so speaking valves are also there, which can be inserted into the tracheostomy tube, and they can help in the patient in phonation and helping in better recovery, and psychological stress will be less in those cases.
Thank you. And now we all are aware that in the critical care environment, there is always a discussion going on about the early versus the late tracheostomy. So there are different views, but let me listen to Kushagrita what exactly she wants to say and what the literature says about early versus late tracheostomy in critical care settings.
Yes, sir. So basically, the timing of the tracheostomy depends upon the primary pathology that the patient is having, and the duration for which the patient will be tracheostomized, and patient will be like ventilator dependent or requiring that airway. So, sir, in the critically ill patients who require prolonged mechanical ventilation, tracheostomy can be performed early within 1 week. So if the tracheostomy is, if the patient is to be intubated for more than 14 days, then within 2 to 10 days, we can take up the patient for tracheostomy. And in the patients who are having head trauma with poor GCS and altered mental status, in that within 3 to 4 days of intubation only, we can go for tracheostomy.
Please show the slide now also. So it just depends. It's not one rule fits for all. It depends upon kind of the patient which we are having, and particularly in head injury patients, when we know this thing that the recovery is going to be very slow, and there is no harm in going for an early tracheostomy. So now this after this everything like in a tracheostomy, how to do, what kind of the things are available. Can you describe that? How does this tracheostomy help in the overall well-being of the patient?
Sir, as already told earlier, sir, there will be lesser work of breathing in these patients. Oral hygiene will be better. Incidence of ventilator-associated pneumonia is comparatively lesser in these patients. Hospital stay and hospital cost will be lesser. ICU stay will be reduced. There will be decrease in hospital mortality also. Improved comfort of the patient will be there. Psychological stress of the patient will also be less, and there will be less risk of tracheal stenosis, and better laryngeal function in the long term can be there in these patients.
Okay, thank you. And this is the way that tracheostomy helps over there. Now, the very important question, which is very, routinely asked, is about the care of the tracheostomy. You know, this is very pertinent for the critical care physician or the residents who are working in a critical care. That this can be a source of VAP also if it is not properly cared. This can be a source of serious emergencies if it just comes out over there. So this care of tracheostomy has got a bundle of care is available. Can you describe what is, how will you do the care of tracheostomy?
So the care of the tracheostomy can be broadly divided into 10 main headings. Sir, the first one is essential and the safety equipment of the tracheostomy care. Sir, in that we have to check the tracheostomy care in equipments daily, and the staff should also take the over of this equipment that should be present wherever tracheostomized patients are.
Kushagrita, can you just hold on, please, because somebody is asking. Please share the previous slide of benefits of tracheostomy. Just show them the slide, then you can continue with an answer.
Yes, sir.
You can, read out the slide for the people, please.
Yes, so there's a decreased incidence of ventilator-associated pneumonia. There is a decrease in hospital mortality, early weaning, less need of sedation in these patients, shorter ICU and hospital stay. It decreases overall ICU cost. There is decrease in risk of tracheal stenosis, therefore better long-term laryngeal function outcome also. There is improved patient comfort, lower work of breathing, improved oral hygiene, oral intake is more likely in these patients, and there is earlier ability to speak, thereby psychological trauma and stress is lesser in these patients.
Okay, thank you. Shireen will be coming on to your question also in the, the further coming slides over there. So please continue with the next slide, please.
So we were discussing about the care of the tracheostomy. So the first one is equipment and safety equipment should be checked. So there should be proper over among the staff also and the residents also whenever there's a tracheostomized patient that is present. So then the second one is the humidification. As in our case also, humidification was one of the main reasons, could be one of the reasons why the tracheostomy tube is blocked. So there are various ways in which humidification can be done. It can be through droplet, through use of HME filter, or through the use of wet gauze can also be placed over the tracheostomy. So the third one is suctioning. Regular suctioning is important for these patients. So then cleaning the inner cannula of tracheostomy tube. This is more important in double lumen tubes in which there is an inner cannula. So if there are any crustaceans on the inner cannula, that can be removed. And then if there is a damage to the inner cannula, so without changing the entire tube, only the inner cannula can be changed and the tracheostomy tube can be kept same. So then is tracheostomy site care and dressing. So mostly after tracheostomy, the next day only we do the tracheostomy site dressing. And if there is any visual soiling that is present on the tracheostomy, then the tracheostomy dressing has to be changed then and then. But otherwise, once daily, at least the tracheostomy dressing should be changed. And it should be done with clean sterile gauze pieces after first cleaning the area. Next, moving on to tracheostomy ties care. Tracheostomy tie care are also equally important. So because any soiling in these can also lead to the infection, which can further spread into the respiratory tract of the patient. So then optimum cuff pressure has to be maintained and the cuff pressure should be checked in each shift of the patient, each shift of our duty also. So then changing of the tracheostomy tube. So for this, there are different guidelines for percutaneous tracheostomy and for surgical tracheostomy also. Then there should be a communication and weaning plan. So a multidisciplinary approach is required between the speech therapist, the anesthetist and the staff also about the weaning of the patient and the communication about this. And so finally, the most important step, that is the decannulation. So sir, various preparations are to be made about the decannulation.
We'll come on to that, but before we proceed further, show the slide of the care of tracheostomy, please.
Yes, sir.
So this is the bundle of care for the tracheostomy. And there is one question over there for you, Kushagrita, that is there any decrease in mortality rate in early versus late tracheostomy?
So it depends upon the primary pathology of the patient, sir, because in the neuro patients, mostly we have seen that the outcome has been better when we did the tracheostomy within 2 to 3 days of the admission to the ICU. So not mortality as per se, but some morbidity definitely has decreased.
Definitely, this is what even the evidence also says. The literature, they have more focused on the morbidity of the patient, and early tracheostomy, particularly in those cases where the recovery is very slow and we know that it will take a long time, definitely benefits the patient in decreasing the morbidity. And there are other two questions. I think they can be taken later on once this thing is done. Okay, so this once the criteria are over of so what could be the highest criteria for decannulation? How to proceed about it?
So when we are planning to take up a patient for decannulation, various things have to be looked upon. We have to see that the ventilator support is no longer needed by the patient. Patient can maintain the patency of the airway and they can control their airway on their own. There is absence of any respiratory distress in the patient. Hemodynamic stability is present in the patient. The arterial blood gas analysis that shows no abnormality as per se. There is adequate swallowing that is present. Proper cough reflex should also be present, and the patient should be able to expectorate the secretions that are accumulating or that are being produced by the body. And so for the process of decannulation, sir, I would like to show an algorithm which would help with this.
Please show that algorithm also, which is very important.
Yes, sir. So basically in this, we have to see the checklist has to be done, which basically includes all the prerequisites that have already been discussed. That includes intact sensorium, successful prolonged spontaneous breathing trial, characteristics of secretions and need for suctioning. effective swallowing and coughing should be there, and there should be a patent airway. Now, there are basically two case scenarios. In one, there is short duration of mechanical ventilation without suspicion of neuromuscular weakness. So, sir, in this, the decannulation technique that we follow is cocking trial. Sir, in this, basically, we are blocking the tracheostomy tube, and then we are seeing that whether the patient is able to tolerate this. If it is successful, then we are going to decannulate the patient. But if then there's a failure, then we'll move to the second case scenario, which is also followed in the case when there is long duration of mechanical ventilation with suspicion of neuromuscular weakness. So, sir, in this, the decannulation technique that is followed is downsizing and blocking. So in this, we are gradually downsizing the tracheostomy tubes that are inserted in the patient, and then we are blocking them gradually, as was done even in the cocking trial. If it is successful, then we decannulate the patient. But whenever there's a failure, we have to upsize the tracheostomy tube as per the requirement of the patient and resume ventilation if required. Like if the patient has gone into respiratory distress, that depends upon the condition of patient and varies from patient to patient. And then further, fiber optic evaluation or bronchoscopic evaluation has to be done to identify the cause that is there. And then the cause has to be corrected, and then we have to proceed with a further plan.
So this is basically a very summarized kind of a thing for the decannulation algorithm, and it's always very useful when you plan to do decannulation. But it's not that you are always successful. So my question to you is, what do you understand by failed decannulation?
Sir, failed decannulation basically means that when there is a need to reinsert the artificial airway again within 48 to 96 hours after the tracheostomy tube removal, which could be because the patient is not able to maintain the airway patency and the patient has again gone into respiratory distress. So we have to again reinsert the artificial airway in that patient. And so depending on that, we can secure the airway. If the stoma is open and patent, we can go for insertion of tracheostomy tube, insertion only of the same size or smaller size. And sir, in some cases, we have to even proceed with the endotracheal intubation also. So that is why it is told that whenever we are decannulating a patient for at least 24 to 48 hours in the ICU also, near the bedside of the patient only, we have to keep the intubation trolley also and the things required for tracheostomy also ready by the bedside of the patient.
Show the slide, please. Sharbita, the slide for the, do you have the slide? Yes, difficult or failed decannulation. Okay. Kushagra, now we'll be moving towards the questions which are posted over there in the chat box. Okay.
Yes, sir.
So this is a very good question which has come to us, and though we may not be, very frequently encountering this situation for us. How do you manage the airway if tracheostomy tube comes out in ward?
So we can reinsert the tracheostomy tube of the smaller size, and at the same time, we should have the ENT surgeon on the backup also. We can try doing the endotracheal intubation, but for that, someone has to like properly bandage the stoma or hold the stoma together so that the air doesn't leak out from that.
Actually, Kushagrita, since this particular thing is happening, this kind of an emergency is happening in the ward, and where you have no control over the logistics as well as the situation over there. And if you have been called to manage the air over there, the best thing is the anesthetist should carry with him a small size endotracheal tube. Once ever you get a call about this, the accidental coming out of a tracheostomy tube, and you have to maintain the airway. So what happens is, because if you try to reinsert the tracheostomy tube, first of all, you don't even know in that small period of time whether how old is this tracheostomy, and second thing is, in a panic, you might create a false passage also. So it is best is that first of all, the immediate requirement is the oxygenation. You insert a smaller side tube, do very effective suctioning, and if the oxygen is available, attach it to the ambu and start doing the ambu ventilation of the patient. Once the patient is stable, out of that kind of an emergency, and the ENT person has also been called, then either you do the thing over there, depending upon the kind of patient it is, or if it is felt by the team that it is better managed in the OT, then you must take the patient into the OT. Okay, so I'll come to this PCT, better than surgical tracheostomy, later on, and there's a question by Dr. Kiran, contraindications of tracheostomy. Do you have any answer for that, please?
Yes, so contraindications for the tracheostomy, in this, if the patient is having any neck swelling or any contractures in the area in which tracheostomy is being performed, then if the patient is having any coagulopathy, in those cases also tracheostomy, we do not usually proceed with the tracheostomy per se if no urgency is there in these patients. So then,
So I'll let you know a few of the things. There is still recently, one patient admitted to our ICU who had some sharp injuries over to the neck.
yes, sir.
And the surgeons wanted to operate that patient over there, but they were not willing to carry on with the tracheostomy because they have this feeling that probably doing a tracheostomy, both ways it may infect the wound as well as the tracheostomy. So sometimes this can be a contraindication to tracheostomy, and you might have to proceed with the prolonged endotracheal intubation. And then whensoever this cervical pathologies are taken, you are doing the cervical, any operative procedures on the cervical spine, the neurosurgeons, mostly they are not in favor of going in for a tracheostomy, even if they know this thing, that the patient is quadriplegic and will require a longer bit of time for the ventilation, because they feel that there will be a surgical site infection if they do tracheostomy. So this can be few of those contraindications for the tracheostomy, which may be iatrogenic, the surgeon doesn't want, or which may be logistically related to the area where there is infection or kind of an abscess or kind of an injury, that it is probably difficult to maintain. And then if there is these are the basic those things. So next question is by Rajiv Jindal. How frequently should tracheostomy tube should be deflated?
So deflation, sir, it basically depends on the condition of the patient. When the patient is on ventilator, at that time, usually we are not deflating the tracheostomy tube. But sir, when later on, while feeding the patient, we are when we are downstepping the patient, at that time, we are deflating the balloon of the tracheostomy tubes.
So I tell you let me answer this question also. How frequently should be deflated? First of all, the deflation should be done in those patients who are off the ventilator into the ICU and they are on the path to recovery and decannulation. Now, why? The question is, why do we require deflation of the tracheostomy tube cuff? Now, when the patient is on the path of recovery and you want to provide the oral feeds to the patient, what happens is this inflated cuff will bulge into the esophagus and the patient will have a lot of difficulties in accepting that feed over there. So the tracheostomy tube has to be deflated, but the protocol is once you are starting for your feeds, what you have to do is make the patient lie spine, do effective tracheal suction, then do within a separate catheter oral suction. Once both of these things have been done, make the patient upright to 45 to 60 degree. Then afterwards, deflate the cuff and then start giving patient food. So every time when the food has to be given, the tracheostomy tube should be deflated. Another theory is that it was proposed previously that it should be intermittently deflated so that there should not be pressure necrosis. But nowadays we are getting high volume and low pressure cuffs, and many instruments are available with us where you can frequently monitor the pressure in the cuff, and if it is in the permissible limits, so there is no need to go in for that. And I'm still leaving that PCT question over here. The next is the question is the dead space difference while using tracheostomy tube and endotracheal tube.
Sir, it will be lesser when we are using the tracheostomy tube as compared to the endotracheal tube. So because upper airway is basically omitted in case of
upper airway is already being bypassed with endotracheal tube. So how much is the dead space difference between the endotracheal tube, which has already bypassed the upper airway, and tracheostomy tube? Endotracheal tube is a lengthy thing. Tracheostomy tube is a smaller thing.
Apparatus dead space will be lesser in case of tracheostomy tube as compared to the endotracheal tube, sir.
Okay. So next question, somebody has asked you, how do you block the tube?
Sir, we can use the obturator also that is there with the tracheostomy tube for blocking the tube. And sir, other way we can create like with the gauze piece, we can create a block, and with that also we can, like, if no other thing is available. So
any precautions which you will take if you are blocking the tube?
So suctioning should be done prior to blocking the tube so that no retained secretions are present inside.
Anything more?
And the cuff should be deflated, sir.
Either the cuff should, this needs to be, it's very important thing, the cuff should be deflated. Otherwise, I mean, you will be choking the patient,
Yes, sir.
right? So then the question is how frequently the suctioning should be done while tracheostomy tube care at ward, at ICU and at home.
Sir, at
This is a question with respect to suctioning. Let's answer about the ICU first, and I'll answer about the ward and home. How
Yes.
frequently the suctioning should be done?
Sir, sir, first of all, whenever there is active expectorations, if they are present at that point, also whenever it is there, we have to do the suctioning at that point only. But sir, otherwise, also at regular intervals, it should be done mostly in the at the intervals of 4 to 6 hours. We are doing the suctioning in our ICUs normally.
Okay, but I would still suggest that if you have a tracheostomy tube and the patient is having a ARDS kind of a feature, it's my own experience that doing some 10 to 15 seconds of suction every 2 hourly will definitely make a difference. But this is what we can comment about in ICU. And to talk about the ward and home, it is basically, I can talk about the home because for us, when we are discharging the patient with tracheostomy, so the kind of instructions which we give to the patient's relative is that at least at home, they should have two kind of suction operators available. One which is a pedal suction, another one which is an electricity operated, because in case the electricity goes off, still you have a pedal suction available. Then we teach them to listen to some kind of gurgling sounds if they're coming, if through that, or if the patient is having difficulty in breathing. So at least every 6 hours, there should be suctioning, minimally suctioning should be done over there. Then we also tell them that the suction should not be prolonged, lest it sucks out the more of an air in the lungs. So each suctioning event should not go beyond 10 to 15 seconds. Next question is, the patient is coming with stridor for tracheostomy. Should we do tracheostomy under local anesthesia or general anesthesia?
Sir, we should do it under local anesthesia, sir, because if we go for general anesthesia, sir, in that airway collapse will occur and then the problem will be further exaggerated in that patient.
Absolutely. Already the patient is stridor means is hypoxic, and if we go in for a general anesthesia, and we know that if you are requiring tracheostomy, that means you do not have a control over an airway. So the preferable anesthesia will be local anesthesia. So what advances for tracheostomy tube care are given to the patient discharging with tracheostomy tube? I think we have answered this question.
Yes, sir.
And there is one question about drainage of lung segment during chest physiotherapy, and this is for Anmol to answer. But let's first complete our questions. What is the cause of surgical emphysema in post-tracheostomy patient?
So surgical emphysema, sir, it mostly occurs when there false track that was created in while doing the procedure. That can be a reason. So then when the sutures that are taken, there can be leakage around that, and that can lead to the creation of subcutaneous emphysema in these patients, sir.
Okay, fine. Thank you. And another question is, what is the cuff pressure maintained in the tracheostomy tube and how frequently it should be monitored?
So 25 to 30 milligram of mercury is the pressure.
Not milligram, millimeter.
MM of Hg, sir, MM of Hg, sir.
Okay. So ideally, it should be, somebody has answered about 2 hours in ICU.
Yes, sir. So, but at least
another thing is, somebody is writing in ARDS, SOS suctioning is, I fail to understand. SOS suctioning, not routine. Let me talk about this question, a little bit of this, and what the protocol which I follow in my ICU over there is that I know, and I have seen differences in the management of various people. If you go in for a repeated suctioning in ARDS, the PEEP which you have given to counteract that ARDS, the PEEP will get lost. So I am talking about only those cases in the early stages of ARDS, or when the full-blown ARDS is not developed. Going in for every 2 or to every 4 hour suctioning will be better. But if the patient is having a full-blown ARDS and you have already given the patient PEEP, so going in for frequent suctioning means loss of PEEP and loss of the advantage of the ventilation. So the PEEP catheter should be used in those cases. And I recommend doing suction every 6 hours and not more than that. Are there any chances of tracheal trauma due to intubation leading to pneumothorax with crepitus? We have answered this question, Kshagrita.
Sir.
Why do we have to change from PVC to metal tube while discharging?
No, sir, we are not changing, sir. We are discharging on PVC tube only.
PVC tube only. So nowadays we are not changing to the metal tube.
Yes, sir.
Somebody is asking, can you please repeat the answer regarding the dead space?
So apparatus dead space is different in both the like in tracheostomy tube and the endotracheal tube, sir.
See the volume of the tracheostomy tube versus the volume of the endotracheal tube.
Yes, sir.
So naturally, the volume of the endotracheal tube is more than the volume of the tracheostomy tube. So the dead space is more in the endotracheal.
Endotracheal tube, sir.
So then what precautions you take for tracheostomy in COVID patients? Any difference with the regular?
Sir, like when we are doing the tracheostomy or when we are like in what kind
I mean,
of-
tracheostomy COVID patient. Let me put it in this way.
So when we are tracheostomizing the patient, sir, we should like aerosol generation should be lesser. So if the patient is already intubated and we are going for the tracheostomy, so we should make sure that the patient is sedated and paralyzed so that there is no aerosol generation is lesser as the patient will bug less. And sir, more importantly, sir, proper equipment protection should be taken. And sir, another thing is that we can like endotracheal tube, we can push it forward also when we are taking the when we are taking the prick for the tracheostomy, when we are making the incision for tracheostomy.
Why so? Why so?
So because in that the gush of air that comes out when we are putting in the tracheostomy tube, that will not come out because the tube will be inner, so that it will keep on ventilating and that gush will not come because it will be distal to the incision site, sir.
Okay. Now the another question in the chat box is that the patient with large goiter landed up in cannot intubate, cannot ventilation situation, and how to secure the airway in these cases. I mean, it's free for everybody to answer. And Kushagrita, can you answer this question? Is a large goiter?
So we should go for, but cannot intubate, sir. Otherwise, we should go for fiber optic in these patients. But sir,
No, this is a situation which is cannot ventilate, cannot intubate.
So we have an answer from Dr. Nishu. She says you lift the large thyroid mass and then intubate the patient.
Okay. Last answer is that.
Yes,
Of
sir.
course. So that is when you were saying goiter. So normally it is manageable in the situation that you can, ask the assistant to lift the mass up. Once the mass has been lifted up, then the ventilation is also possible as well as the intubation. When it comes to the tracheostomy part, I will suggest that once intubation has been done and the surgeon has taken that mass out, and then you have to assess for any kind of tracheomalacia if it is in a prolonged goiter. If it is not there, then there's no need for an tracheostomy. But if there is a tracheomalacia and we fear that there will be collapse of trachea, so it is then it becomes important to go in for a tracheostomy. So for a large goiter, when CICV situation, lift the mass up.
yes, sir.
Then how to manage surgical emphysema that develops during change of tracheostomy tube, because hypoxia might be happening at there and it may be rapid development of surgical emphysema.
Surgical emphysema mostly it resolves on
That is during the change of tracheostomy tube, he is asking.
So that can be because the tube has gone into the false track, sir.
The management of surgical emphysema in this case is, first of all, be sure that you do not create any kind of a false passage. If the false passage has been created, please take the tracheostomy tube out immediately and try to intubate the patient from above. Once the patient has been intubated, you can, through that tracheostomy hole, you can see that particular endotracheal tube going. With that guide, you can put in a tracheostomy tube over there. This kind of emphysema will resolve on its own once you have secured the airway and you do not provide any further chance of air loss from that false passage leading on to the emphysema. After suctioning, we might need to perform, yes, of course, in ARDS, after suctioning, we might need to perform the recruitment maneuver for the patients, but once that PEEP catheter has been utilized, of course, it can be situation based. Aren't there increased chances of aspiration when we are feeding the patient with cuff deflated? No, there are no increased chances of aspiration. If there is a chances of regurgitation subsequently leading to aspiration, that means patient is not conscious enough, fit enough to have anything orally. So please do remember that I am telling you this thing. This is to be done in those patients who are tracheostomatized, who are off the ventilator, who are fully conscious, and they are on the path of decannulation. And we want to provide them the food And for this is a standard known practice that only in these kind of patients, after proper oral and tracheal suctioning, you go in for deflation, but with the patient in a 45 to 60 degree position. And then once the food has been given to the patient, then inflate the cuff again. Lift the thyroid mass. Okay, this has been done. Somebody has given that the reverse salix. Okay, we can perform the leak test. So, Kushagrita, do we have anything to tell about the PCT also?
Yes, sir.
So there was a question which said, is PCT better than the surgical tracheostomy?
That is the reason. I remember that question. That is the reason. So, because I have not covered this thing in a tracheostomy, but this is one thing which is in the domain of the critical care physician, and we all are performing PDTs in the ICU. So I'll just have a brief about the PDT, and then we'll answer that question.
Yes, sir.
So it is basically a bedside procedure which eliminates the risk during transportation in very sick ICU patients. It gives the chances of better tracheal healing and lesser chances of stoma infection are also there. There is shorter learning curve in this. Various techniques have been used for PDT, which includes Griggs forceps technique, blue rhino dilator technique, ultra perc technique, percu twist technique, T-dragger technique, and balloon dilator technique. We can use various aids that can help in better outcome of PDT, which include ultrasonography, and fiber optic bronchoscopy guidance can also be used in these procedures. That's it.
So now the thing is that the question by Dr. Neta is PCT better than surgical tracheostomy? Do you have an answer or I answer it?
Sir, it is better in case that there is the wound healing is better in these patients. The overall outcome in the later period is better in these patients, but there are certain cases in which we cannot go for PDT. In those cases, we have to definitely go for surgical tracheostomy.
So the ideal answer is that it's nothing like one particular technique is better than the other technique, because it is all depending on the kind of patient which you are having. If you have a thin, lean patient who is not having any kind of a neck pathology, who is not obese, and where the anatomical landmarks are very clear to be palpated, then PCT is definitely better than the surgical tracheostomy. Moreover, I mean, you don't have to wait for the surgical people to come and perform these kind of things. And like Kushagrita has told you about that the wound is very small and it is up to the size of the tracheostomy tube only. There is not much of the dissection which is required in PDT. So it is definitely better tolerated as compared to the surgical tracheostomy. But this is not something that one solution fits to all the patients. It definitely varies from case to case.
Yes, sir.
Parul, are there any more questions?
Not that I can see, sir, but there are few questions which people have asked from ma'am, Richa ma'am and Dr. Anmol. So if you
Okay.
allow me, can we ask them these
Please.
questions?
Please.
Okay. Richa ma'am and Dr. Anmol, can you please unmute yourself? There's a question, ma'am, that is there any difference to manage percutaneous ICD tubes?
No, per se, there is no difference to manage the percutaneous ICD tubes. The basics remains the same. And the one thing which everyone should do on a regular basis when there's a patient with the ICT insertion or ICT in situ is that you need to observe the tindling effect every day. You need to observe that it's not blocked or kinked every day. And you need to see the daily output every day. So there are certain things which have to be seen, but as such, and yes, you have to be very, very, because since, nowadays, even if you talk about chest tubes, most of the chest tubes, if you see the critical care centers, they are being placed by the anesthesiologists only, either by a anatomical landmark technique or by use of ultrasound. So, in these cases, the only one thing is that you have to be very, very sure that all the eyes, at the end of the ICT drainage, they are inside and there is no subcutaneous emphysema or leak, if one of the eye is left out, one. And the second is the fixation of the ICT tubes. Most of the times when you have put in an ICT, especially anesthesiologists, amateurs who are, learning it, most of the times they'll not fix it. So next time you go, next day, either the tube is out or it is misplaced or it is not draining. So you have to be very, very, very cautious about it. Apart from that, taking care of the ICT is almost the same.
Right. Ma'am, would you like to say something about the commercially available 3-bottle ICD?
The commercially available 3-bottle ICD systems, we all have heard about this Fluorovac system, Aqua systems. They are being used, very, very routinely. And actually the 3-bottle system basically is used to regulate the whatever fluid or blood, mostly fluid and blood, in a very controlled manner. So the suction pressures, either the dry or the wet suction. Dry and wet suction is that you are changing the pressures according either to the suction pressure or by moving the tube, mostly by the suction pressure. They usually kept up to minus 20 centimeters of water. But you have to be very, very sure, in case there are friable lungs or in infants or in pediatrics, these suction pressures, they have to be as low as even 5 centimeters of water or 2 centimeters of water. So, and the 3rd bottle drainage system, one thing with the commercially available 3-bottle system is that you have to be very vigilant when you're using a 3-bottle system. Why? Because in case there's a suction failure, these patients, they will have a tendency to develop a tension pneumothorax. And that is why a 4-bottle system had come into vogue, actually. So you have to, the monitoring and your reflexes, they have to be sharp whenever you're using a 3-bottle system.
So thank you so much, ma'am. Dr. Kroshagrita, this question is for you. How do you prevent tracheal hemorrhage while suctioning?
Agrita,
Yes, sir.
so I would like to answer this question.
Yes, sir.
All
Please.
the residents over here, please do remember that this suctioning is one of the most painful thing for the patient. It is not, if the surgeons provide pain, we also give pain to the patient when we are doing suctioning for the patient. And it's a very valid question, how to prevent the tracheal hemorrhage while suctioning. The most important thing is that the patient should be calm and should not be agitated at that time. And when you are taking that catheter inside, do remember that the catheter is of the quality which has got a round tip and which is not sharp tip. And once you are entering the catheter inside, there should not be no suction attached to the catheter, or if the suction is attached, it should be clinched, right? And go very slowly. If you encounter any kind of resistance, please do not force the catheter over it. So that is very important. So if you do like this, once the catheter is inside, then definitely, apply the suction not more than 10 to 15 seconds. And with that, you will be able to prevent hemorrhage to the patient.
Right. Sir, I think we have a lot of...
One
yes,
thing
ma'am.
I'd like to just tell the residents before we end up the discussion is that when we were talking about the re-expansion pulmonary edema, first and foremost, you have to remember that it is basically, the mechanism is the increased vascular permeability secondary to the reperfusion damage by the free radicals. And that is why we always say that you should drain the fluid, the massive fluids, very slowly. The second thing which I wanted to tell was that whenever you have a short case on ICT, please read about intrapleural pressures, please read about what are the maximum pressures generated in inspiration, expiration, tension pneumothorax. This is basic physiology. So you will be asked these questions in your, Viva, table Viva. And apart from that, somebody had asked that why 100 centimeter, and there's a person who has written the maximum intrapleural pressure which can develop in tension pneumothorax is minus 80 centimeters of water. So to maintain a gradient, that is why we always keep a chest tube below. And that is why all the residents should ensure that the, the bag is never at the level of the chest, at the level of the patient, even when you are transporting a patient. Okay. So thank you so much.
Actually, I think this is a very relevant topic, both practically and for the exams also. So we have a lot of questions, and a very heated discussion is also going on, but we have to keep up with the time. So we'll just take the last question, which is given by Dr. Anoop. So can you name the DLT used through the tracheostomy stoma?
Even I don't think so. Even I'll be able to answer.
No. There are specialized DLT tubes which can be used through tracheostomy stomas. I do not remember the name, but it is definitely given in the Miller. If you open the chapter of thoracic anesthesia and Miller, the DLT tubes which are used through the tracheostomy, it is given there. It's a short DLT tube and I cannot recollect the name, but they are commercially available. But if you actually need it, you'll have to talk to the person so that they can make it available. You'll not get it over the counter just like that.
Okay, so there's an answer. Somebody says we can pass a bronchial blocker through the tracheostomy tube.
Yes, you can.
Lung isolation.
Lung.
So, Bajwa sir, your comments, please, before we end the session.
I'm left with no comments. The two young PG students, the Anmol and that Kushakrita, they were given a short case and they had to answer for a long case. And the person, Dr. Paltasar and Richa. Anyway, Dr. Paltasar's question, you listen to his question, you will be awestruck. The way, but today he supported so much. Well, it's very difficult to answer the questions of Dr. Palta if these PG students must be knowing during their routine operation theater duties. I know how Dr. Palta can be, devastating with sometimes questions. But today he was very loving and he was supporting you. So that's a good discussion.
It was a very good discussion.
And the idea behind the whole this case discussion by the PG student is that the examination pattern, is almost same throughout the country, where the long cases and short cases are done. The PG residents who are attending these classes, they should be seeing themselves at the places of the presenters, because tomorrow they will be presenting in front of the examiners. So rather than asking some, a very high-fi question just to prove that knowing is better, is rather going for a very pertinent and clinical questions, which they will also be facing during their examination. The idea is not to discourage any one of us. It's a very gentle discussion. And suppose the teachers like Dr. Palta sir and Dr. Richa are there, so you always will be empowered with a great knowledge, which will be very helpful for your examination. Out of the questions which were discussed today, if you get these short cases in your examination, you will be able to answer more than 95%. That I'm sure of. Still, there will be many questions, but these were the short cases. We cannot take up all those questions now with the shortage of time also. But really hats off to both the PG students. They did a marvelous job. And the questions they were answering, like the volley fired by Siddharth Basu, I know in the quiz, whenever he used to ask a very rapid round, the questions were being asked in the chat box and they were answering immediately. So that means they are well prepared for the examination. I know they will be doing very well in their final examination. But equal hats off to Dr. Baltasar and Dr. Richa. They handled the entire session very, very meticulously. And
Thank you, Dr. Bajwa.
Thank you so
all
much,
the clinical
sir.
relevant points were touched.
But I must admit that one question has remained unanswered by Dr. I think Rajiv Jindal about the incidence of stenosis, tracheal stenosis between the conventional versus PDT. And right now I have not have the necessary knowledge and I don't want to give any kind of a wrong answer. So I will definitely go. Today I have also learned one question which even I can't answer.
It's a learning phase.
That also depends on the data. How many of us really report the data of the tracheal stenosis, because these patients may be getting tracheostomy at some places and down later on presenting to some other places. How much data we really record and how the data appear in the journals or in the textbooks. Until then, we will not be able to get the real incidence. But real incidence, I will encourage everybody that if you are getting good cases done in your institutions or hospitals, you can upload your data on the ISA apps. The directory is there, ISA directory is there. Nobody will be, their identity will not be revealed. You can keep on accumulating the data. That data will be used by the ISA later on for the betterment of the patient care only. So that's the only thing we can say, sir, at the moment.
Okay.
Finally, we've got the answer from Kushagrita herself. She says that it is the Roosh DLT tube which can be used.
Yeah, thank you, Kushagrita. I was just, faltering with the name, but yes, thank you.
Good.
So,
anybody wants to give their suggestions for these type of cases? Anybody, just one or two comments from the general members also. There are senior people also who have joined here. Anybody wants to give their suggestions or something new to these, whatever already been discussed? I don't think so. Nobody is raising hands. Let me say unmute. Let me one minute. We have got 2-3 minutes. Anybody wants to say anything? Any suggestions? Or anything not discussed in this class?
So there's another question. Can we take up that question if you allow? Because people,
the
lot of
last
queries,
question only.
some very good speakers and teachers. So the question is, what are the type of speaking valves?
Kushagrita?
So they are basically coming like different company walls that are coming. There is one-way speaking walls that is present. Then there is the walls through which ventilation can also occur and speaking can also occur. Sir, that only I am.
Need to go further for this, Parul,
Yes,
because
sir, sure.
it's not in the domain over here. So that's the
Right, sir.
reason.
But
Okay,
I think she answered very well. She answered very well the way the PG should answer in the examination. If you don't know the answer properly, limit yourself to your knowledge domain only.
Sir, there is a query for you, Pajwa sir, and
Yes.
that is, what is the topic for the next class?
Next class, I think, because the examination is in the May, June, we will be coming up with the cases only. I've got the list of long cases, maybe some good long case. If any PG wants to get particular difficult case, we can present that. I think for the next 2 months, we will be getting for the long cases and short cases. Theory they can prepare, they can manage, but the long cases discussed here, it is just type of a revision for them. So in the coming almost 2 months, we will be presenting with the cases only, long cases and short cases.
Richa ma'am, you were saying something. I think I interrupted you. I'm so sorry.
Hello, not at all. Please don't say sorry. I was saying that yes, she was right. There's a when we were talking about speaking valves, there's a one-way valve which can be attached to the tracheostomy, which allows the air to enter, and the patients can speak through that. So basically, the speaking valves are usually they are commercially available and they're given by the ENT people usually. We are not prescribing it from the ICU per se, but yes, they are available. They can be used, and the patient gets acclimatized to it within 2 to 3 days. That's not a problem.
Okay.
And especially in children, in patients who are tracheostomized for long times, or in children, it is always imperative to give the speaking valves as soon as possible so that they can communicate, as early as, they can.
We are blessed to have Dr. Naveen Malhotra sir with us, and sir has commented in the chat box that there are 2 types of tubes which can be used, Montgomery tube and aspirated trach tube. Sir, please kuch prakash dal dijiye. Naveen sir?
You see, at times patient may land up in an emergency with aspiration of tracheostomy tube, especially the fenestrated one, and that's a real dire emergency. And it has to be, you have to be prepared for everything. I have encountered such case where patient landed up in emergency with aspiration of tracheostomy tube, the fenestrated one. And fortunately, he was able to breathe. And we had prepared for a femorofemoral bypass also in case. But fortunately, we were able to remove it and salvage the patient. And also Montgomery tubes, we all know they are silicone one, and patients with Montgomery tube may come for anesthetic management. So we should be knowing about their attachments and or removal of the Montgomery tube followed by the surgical procedure. Or after the surgical procedure, patient is put on Montgomery tube, which is made up of silicone with T-limb and without any cuff. So this is just to sum up about the topic, because these are the things which are asked in the Viva, the anesthetic management for an aspirated tracheostomy tube and the Montgomery tube.
Okay.
I'll also go through that. Thanks for this edition, and I'll read about that also.
For the next, I think, class, it will be informed on Wednesday, so that all the postgraduate students can come prepared with that particular type of things. I don't, that may be the reason of asking this about in advance about the class for
Yes,
the
sir.
case presentation for the next session. Definitely, you, when you go through that case, you come prepared. So it will be conveyed to everyone in the groups of
And
ISA.
they can pile up their questions also, sir, by that time.
Questions to become too many. So whatever the questions they can send on the mail, we will be providing them the email in that message, so that they can give a questions format, so that maybe around 100 questions and 60 of them may be very common. So many
Right, sir.
common questions will be there. So we will be dealing in that way, so that we will take one case at a time now till examinations are over. Thereafter, we will proceed with our normal routine classes also. Along with panel discussion also will be the part of these classes now for future. Every 15 days, we will have one panel discussion with 4 or 5 good teachers, and maybe having students also there with that thing. Different thing, different from the normal routine now. Learning is interactive learning is the best way of learning, I think. Today, I am really proud that both the girls, they were answering like anything, whatever was being asked in the chat box also. That's good.
Thank you, sir.
Really feel proud of my alumni also. That's, I think, it's a good. Fine.
Thank you, Bajwaji. Thanks a lot. You're always a great man. Dr.
Thank you,
Naveen,
sir.
thank you very much.
Thank you, sir. It's pleasure
Thank you
interacting
so
with
very
you
much.
online. And yes, we remember good times spent together in PGI and GMC.
Yes, yes, definitely.
And
So, sir, we can have a virtual clapping for all our both
Yeah.
the postgraduate students.
Okay.
not virtual, real clapping.
Real clapping, sir.
Yes.
Real
And
clapping.
thank you, sir.
Thank you
And
so much.
sir, can we
Thank
close
you.
the
Thank you
session now
very
with your
much.
permission?
Yeah. Last, thank you to Parul for
Thank you so much, sir.
hosting
Thank you,
in the
Naveen,
group.
sir. Thank you, Bajwa, sir.
Thank
and
you.
thank
Good
you so
night and
much,
long live
Dr.
ISA.
Long
Long
live
live
ISA. God
ISA.
bless the students for their coming exam. Best of luck to all. Thank you.
Thank
Yeah.
you, Anmol, and thank you, Kushagrita.
Thank you so much. Thank
Good night.
So with this, we come to the end of the session. Thank you to both our chairpersons and to the postgraduate students. Best of luck for your forthcoming exams. Thank you, Dr. Naveen Malhotra, sir, for joining us. And thank you so much, Dr. Bajwa, sir, for starting these sessions.